Welcome. When you first see a dizzy patient, your exam has already begun. Before you do any fancy tests, before you even think about hints or the Dix-Hall pike, those first 60 seconds of just looking at them can tell you almost everything you need to know. In this explainer, we're going to break down that crucial first impression, the 60-second read.
So, let's just kick things off with a pretty provocative question, one that gets right to the heart of why these bedside skills are so vital. Is it actually possible for a simple 30-second test, I'm talking zero equipment, to be better at spotting a cerebellar stroke than an early MRI?
The answer is a huge, resounding yes. And the best part? This incredibly powerful diagnostic tool is available to every single one of us. It's right there at the bedside, basically hiding in plain sight. And we're going to get to exactly what that is in just a moment.
First things first, let's talk about that high-stakes first impression, what you can learn before you even lay a hand on the patient. We call this the 60-second read, and really, it's about using the patient's appearance, their posture, and the way they walk as a powerful, instant diagnostic filter. This simple observation helps you immediately start sorting patients into two big buckets, the benign peripheral causes and the potentially dangerous central ones. It basically frames your entire encounter right from the get-go.
So, let's start with the patient at rest. What can their behavior tell you when they're not even moving?
Okay, so check this out because the contrast here is just night and day. A patient with a peripheral issue, say vestibular neuritis, is absolutely miserable. They're going to be lying perfectly still, eyes shut tight, looking pale, feeling sick. But the central patient, they might have some really serious findings on exam, yet they can look surprisingly okay. And that disconnect, that dissociation between how they look and what you find, that's a massive clue for a central cause.
Of course, a patient looking completely well is also a diagnostic clue, right? Someone with vestibular migraine or PPPD will typically look totally fine between their attacks. And a patient with orthostatic dizziness, they look great lying down, but the story changes completely the moment they stand up. So yeah, even a normal appearance is a critical piece of the puzzle.
All right, now we move on to what is, without a doubt, the most decisive part of this initial assessment, their gait.
And this quote right here just says it all. It's blunt. Gait is our most sensitive test for spotting cerebellar problems, and yet it's the part we most often skip. So let's be clear, every dizzy patient who is able to stand must be walked.
Interpreting these patterns is absolutely key. A normal gait is reassuring. It points you toward peripheral or orthostatic causes. Veering to one side is pretty nonspecific, but that wide-based, unsteady, ataxic gait, that is a huge red flag. You have to assume it's a cerebellar lesion until you can prove it's not.
And that leads us to this critical point. If your patient, who's got this acute, nonstop vertigo, cannot stand up without help, you have to assume they are having a cerebellar stroke. Why? Because patients with something like peripheral vestibular neuritis can almost always stand, even if they're really unsteady. The inability to simply bear weight is a totally different ballgame, and it demands urgent action.
So, this brings us all the way back to that first question about a test that can outperform an MRI. The power of that observation is captured in this one single number, 95%.
That's the specificity of this sign. Truncal ataxia, so bad the patient can't even sit up on the side of the bed without support. If you see that in a patient with an acute vestibular syndrome, that simple observation has 95% specificity for a cerebellar stroke. That is the 30-second test that outperforms an early MRI.
So after our first look and our gait assessment, how do we fold this into a quick, really focused neurological exam?
The goal here is a rapid 2-minute screen. We are not doing a full neurology consult. We're targeting the systems that are most vulnerable in a posterior circulation stroke. That's your eyes, your face, your speech, and your coordination.
And specific findings can point you to specific locations. As you can see here, things like crossed sensory findings, where the face is affected on one side and the body on the other, that's a classic sign of a brainstem lesion. New hearing loss on one side points you toward the AICA territory. It's almost like a neurological roadmap.
And please remember this critical pearl. That old rule about trying to explain everything with a single diagnosis, it can be dangerously misleading here. A single, subtle central sign, I'm talking a little mild slurring of speech or a slight change in their nystagmus, is enough. You do not need a whole constellation of findings to act.
All right, so let's lock in the most important, high-yield takeaways from all this.
First, that initial 60-second read is your diagnostic anchor.
Second, gait and truncal stability aren't optional extras. They are your absolute highest yield tests. And third, a single subtle central sign is all it takes. Don't wait for more. These are the principles that will absolutely change your practice. It reminds us that sometimes the most powerful tool we have isn't a machine, but our own trained observation.
In our next explainer, we're going to build directly on this foundation. We'll get into the technical core of the examination, mastering the HINTS exam, understanding HINTS Plus, and correctly performing the Dix-Hallpike maneuver.
Thanks for watching. For more resources for both clinicians and patients, please head over to the website on your screen. And hey, if you found this useful, please subscribe and leave us a rating. It really helps.